So here I have compiled gastroesophageal reflux disease, or GERD, as one of the important one. Then, okay, it is followed by a discussion on carcinoma of the esophagus. Now, see there, let's talk about GERD. And hiatus hernia is also part of this, okay? So we'll talk about that as well. Now, what is GERD? Any symptom or esophageal mucosal damage that results from reflux of gastric acid into the esophagus is known as GERD. So any symptom felt by the patient because of this problem, that is the meaning here, like burning sensation there, okay, it is known as heartburn, very common term in clinical practice. Heartburn is substernal burning discomfort, a chest pain, you can simply say, as a result of reflux of acid and pepsin up into the esophagus is known as GERD. Now, the classical GERD symptoms are heartburn, okay, just now talked about, and regurgitation. Now, this regurgitation is a very typical feature here. Many of us suffer from this, specifically if we take a nap after having a large meal, okay, without proper pillow, then the chance of regurgitation is high. So what I'm saying here is most of us have felt this feeling. And this feeling is having a bitter acidic fluid in the mouth, okay, when we lie down or bend over after taking a large meal. Or if somebody is already having, loose type of lower esophageal sphincter, then even without having large meal, they can have this type of feature, most of the time. So this is known as regurgitation. Let's move on. Now, what are the important reasons to diagnose and treat GERD? Why it is important one? Every student can answer this question, because GERD can result in Barrett esophagus, and Barrett esophagus is a pre-malignant condition. It is a risk factor for esophageal adenocarcinoma. This is a perfect answer you can give here. And another one, because of this recurrent problem, all the time the chest pain occurs, aspiration pneumonia can happen, even aggravation of bronchial asthma can happen because of aspiration. So there is negative impact on the health related quality of life. That's why GERD has to be diagnosed in time and properly treated. Now, a bit of physiological aspect. What are the major physiological mechanisms that protect against the esophageal acid injury? Okay, so in other words, why acid is not going that easily upwards? What's the mechanism? One is a clearance mechanism of the esophagus, that is called peristaltic movement. So this peristaltic movement will quickly push whatever thing is collected here, okay, distally. Second is mucosal integrity. The mucosa which is present here, okay, stratified squamous epithelium is considered as a tough epithelium. Now, it will not allow, the reflux, for example, it will not allow the damage to happen if it occurs, intermittently. But if it is occurring continuously, okay, if it is uncontrolled type of, reflux, then Barrett esophagus will develop. Third one is a lower esophageal sphincter competence. This is probably the most important point here. This lower esophageal sphincter, if it is a competent one, means if it is a working one, it will not allow the reflux to occur. So many of these cases, or many of these patients will have either loose, lower esophageal sphincter, or it is not working at all. And another one is gastric emptying. Now, if gastric emptying is taking time, if the fluid and food, which whatever we take, is is there in our stomach for a longer time, there is high chance of regurgitation or reflux. So these are very easy to understand. Now, after knowing these physiological aspect, let's talk about what are the causes of GERD. Why some of the people develops and some other do not develop. So there are, role of inherited and acquired factors. Inherited runs in the family, hereditary conditions, and acquired, we have got that later in life. The prevalence of reflux symptom is high in the parents of affected people. Okay, that's why it runs in the family. Probably inherited factors play a role here. The concordance of reflux disease is higher in identical twin. Again, it is supporting the inheritance. Genetic factors contribute about 18 to 31% to the cause of GERD. So there is a role. And commonly associated conditions are sliding type of hiatus hernia, pyloric stenosis, and pregnancy. Now, if you remember, I have explained you the meaning of sliding hiatus hernia in the introductory part of this topic. Now, can you tell me what is sliding hiatus hernia? Anybody? Anyone? If you are listening properly there, probably you can answer. Yes?
Sir, lower esophageal sphincter comes out from the esophagus into the thoracic area.
Lower
And we can say
thoracic
that
area.
stomach.
Sir, in
Yes,
the
yes,
lower
yes.
thoracic area, sir, basically.
Yes, Junaid. Yes, very good. Good, Uzair. Yes, Junaid, you are saying something.
Yes,
Yes, continue. Yes.
we can say that stomach pushes up into the lower chest.
Okay. Now, there are two types of hiatus hernia. Okay, this is a part of this class actually. We'll talk in detail there. But right now, you need to understand this. Sliding type of hiatus hernia means the lower esophageal sphincter is slided upwards. It is present in the thoracic cavity. And if it is present in the thoracic cavity, remember, it is not physiologically active. It is lax or loose. So reflux can occur very easily upwards into the esophagus. That is known as sliding hiatus hernia. Pyloric stenosis is a blockage of the pyloric antral channel, isn't it? The pyloric sphincter is narrowed. So it will prolong, okay, the gastric emptying, means the gastric content will remain there for a longer time and the volume of the stomach will increase, and that will help in the causation of reflux. Pregnancy is again doing the same thing. In pregnancy, remember, uh, this is a hormonal state where progesterone is increased. Progesterone is a relaxing type of hormone, so probably this sphincter mechanism is also relaxed there. This is one reason. And another one, there is increased intra-abdominal pressure in case of pregnancy because of the distension of the uterus. And that is also causing prolonged gastric emptying as well as relaxation of the sphincter. Now, some other causes are there, or some less common associations are there, and they are diabetic neuropathy and scleroderma. Now, what is the role of diabetic neuropathy in the causation of GERD? Anybody can explain
Uh,
it here? Yes.
Sir, in diabetic neuropathy, there is damage to the nerve supply of the stomach and that area, and sir, they decrease the peristalsis and increase the emptying emptying time of the stomach, so lead to the GRD.
Excellent. Very
I
good.
mean,
Very good. Very good. Yes. Do you have any other explanation for that? Yes.
sir, it's the same explanation, but sir, just want to add that, sir, that let's say in the type 2 diabetic mellitus, it's more common, sir.
Yes, yes, sure. So diabetic neuropathy means it's a chronic complication of diabetes. Okay, both in type 1 and type 2. If they are chronic, neuropathy can occur. But he's right, it is more commonly seen in type 2 diabetes mellitus because type 2 diabetes mellitus remains undiagnosed for a long time. That's why soon after the diagnosis, it may be diagnosed, I mean, neuropathy can be diagnosed there. That's the only reason, but it can occur in both types. Now, neuropathy means the autonomic nervous system can be damaged, which is supplying our GI tract. So even stomach peristalsis is affected here, and there is prolonged emptying time of stomach. So again, it is the same mechanism which is responsible here. And scleroderma, again the peristaltic movement is a problem because the tissue, the organ in scleroderma is getting tougher, is getting thicker. The peristaltic movement is suffering. So the similar type of mechanism once again. Now, some of the important predisposing lifestyle, okay, lifestyle mechanisms are responsible, and they are obesity, smoking, alcohol consumption, and large and late meals. Absolutely important. We have to explain this all the time to the patient. This GERD is very common in obese or overweight people. On top of that, if they are a smoker and drinking alcohol, it is even has a higher chance. And another important point, even if the person is thin and lean, but if the person's habit is taking very large meal, okay, towards the late part of the night or evening, and immediately after that, if the person is going to bed, this is one of the very important point for the development of GERD. So we should avoid doing that, after taking meal, at least 2 hours, we should not go to bed, or you should not lie down. Okay, move around. Okay, do some other things. Okay, fine. Watch television if you want. Do something on your computer or laptop. Okay, that allow that content, whichever is collected in the stomach, to push downwards. It may take 3 to 4 hours sometimes. Okay, so that is so important from the patient point of view. Some of the drugs like tricyclic antidepressant and anticholinergic, which affect the function of the lower esophageal sphincter, can also result in the same type of problem. Now we are moving on to the more important part. What are the clinical presentation of GERD? Now there are three important way we can describe it. One is called classical GERD symptoms. In the beginning of this particular topic, okay, we talked about that. Second, there may be some atypical or extra esophageal symptom and sign of GERD. And third one, this is a complicated GERD. Okay, some complication have already occurred because of gastroesophageal reflux disease. So let's talk them one after other. Now, look here. The classical GERD is the most common one, or the most common type of presentation. And in this type, patient is having heartburn, chest pain. Heartburn means chest pain. Okay, right at the place of the heart. So patient, the general public or the layman, they think their heart is burning. Okay, there's pain, which is coming from the heart itself, because they don't know medicine, isn't it? They don't know about esophagus, medicine, heart, all these things. So they explain like that. That's why it is commonly known as heartburn. So heartburn means it's a substernal burn or regurgitation, more common after taking the meal, that is known as postprandial, and there is a prompt relief by antacid, because the acid which is refluxing up is causing the problem, and antacid will neutralize that acid. So antacid will give quick relief in the patient. And they may explain exactly like that to you. Doctor, if I take this medicine, the pain will disappear, but it may come back again after a few hours. Now see there, these are the extra esophageal manifestation of GERD. Now GERD is not only limited to the esophagus problem. It is damaging or producing some signs and symptoms in nearby areas also, like in the lung. These are pulmonary problem. If the patient is having bronchial asthma, this aspiration, which is associated with GERD, is making the things complicated there. So exacerbation of bronchial asthma, or some of the complication which develops in bronchial asthma, Or in some of the people, if there is a positive family history, even start of the signs and symptoms in bronchial asthma may also be caused by GRD. And regarding the treatment, it is very interesting thing here. Regarding the treatment, of course, whenever a patient comes with bronchial asthma sign and symptom, you give bronchodilator drug like salbutamol. Okay, that is the first thing we use. Or if it doesn't work, what is another drug we use in the treatment of bronchial asthma if salbutamol doesn't work?
Inhale glucocorticosteroid.
Glucocorticoid.
Yes,
Ipratropium or tiotropium.
very good. Ipratropium or tiotropium or corticosteroid, excellent. What else? What are the other drugs? Other anti-asthma medicine? Montelukast, excellent. Montelukast or zafirlukast.
Zafirlukast.
Yes, zafirlukast or montelukast. Then you can also go for aminophylline or theophylline, isn't it? Aminophylline or theophylline. Or you can also go for, nidocromil or sodium chromoglycate. These are the different medicine which are used in clinical practice. Now, why I am, talking like that? In bronchial asthma, which is exacerbated or caused by GERD, none of those medicine may help the patient. We have to use other type of medicine which will neutralize the acid and which will decrease the reflux there, like PPI, S2 receptor blocker, and some other medicine which will increase the tone of lower esophageal sphincter. Okay. Until and unless we use those medicine along with those typical anti-asthma medicine, patient is not getting better. Aspiration pneumonia is another problem in the lung. Chronic bronchitis is another problem, and pulmonary fibrosis is a long-term complication of GRD. All of these are the damage done to the lung, and all of these are associated with recurrent aspiration. Now, some ear, nose, and throat problem. Okay, ear, nose, and throat, like hoarseness of the voice, quite common. Laryngitis, inflammation of the larynx. Pharyngitis, inflammation of the pharynx. Chronic cough, because of this, patient simply can manifest with chronic cough, chronic irritating type of cough. Globus sensation, this is a sensation of a foreign body in the throat. Okay, globus is a sensation of lump or foreign body on the throat. Dysphonia. Now, dysphonia, what is the meaning? Anyone?
Sir, abnormal voice or hoarseness, sir, mean?
Exactly.
Difficulty in
Exactly. Difficulty, to speak, or abnormal, type of voice development is called dysphonia. Okay. The other term for hoarseness actually. Sinusitis, see there. Paranasal sinuses inflammation, subglottic stenosis, and even laryngeal cancer. So these are some of the extra esophageal manifestations. And let me repeat once again, all of these manifestations are because of reflux of the acid or the stomach content. And others may be dental erosion as well. This chest pain is written here because a lot of differential diagnosis can be thought because of chest pain. So these are the one. Okay. Now, to explain this in a easy way, one picture is included here so that every student can understand it easily. See this? This is a stomach content. This is called reflux. It is going upwards into the esophagus, and it may reach so high that it may trickle forward and downwards into the airway and doing all the problem which were listed there, or in the area where it reach, it can do a lot of problem. This is the mechanism. Now, the third variety, what are the symptoms of complicated GRD? If complications occur, then how the patient manifests? The patient presents with dysphagia, that is difficulty swallowing. This is known as dysphagia. Now, food got stuck on the throat. Patient may complain like that. Doctor, I'm trying to swallow, but I think food is constantly getting stuck there, and I cannot swallow properly, or I am having a lot of discomfort or difficulty there. This is dysphagia. So many causes are there for dysphagia. We'll talk about this later on. Udinophagia is a painful swallowing. Now, there is a difference between dysphagia and udinophagia. Dysphagia is a difficulty to swallow. Udinophagia is painful swallowing, but the patient may still be able to swallow. Okay, that is udinophagia. Bleeding because of the esophagitis, because of erosion of the mucosa, patient may develop bleeding from that area. Now, what happens? How we diagnose if esophagus bleed? Where that blood will go? Yes, where?
Sir, vomit.
Sir, in the stool,
The stool, sir.
So I already got answers. Yes, very good. I already got answer from you. Sometimes the patient may vomit it out, and sometimes it may go to the stool and come outside. So it is known as hematomesis and melena. Hematomesis and melena. Hematomesis means vomiting of bright red blood because it is in the esophagus. That blood may not be altered or digested till now. But if it is a bit of larger amount, if the patient swallow, then the stomach acid will act on that blood and it will be converted into acid hematin. Now it will come out in the stool as melena, that is altered blood, a dark tarry type of stool. So see there, this is important knowledge. Don't worry. After like maybe in the pediatric in the next class we'll talk about GI hemorrhage. During that time we'll talk extensively regarding this. Now let's make this discussion as the last discussion for today, because this is a long session for you guys. Now at the end we should know what are the diagnostic tests, okay, to confirm GERD and when to perform them. What is the time? What is the right indication to perform the diagnostic test? See here. If the patient is having classical symptoms like heartburn, regurgitation, okay, and those things, then no diagnostic tests are needed. If the person is obese or overweight, okay, if she is pregnant, isn't it, and those things, then no need of any investigation. This is straightforward diagnosis, so go for the management. But in certain other situation, okay, we need to do a test. These are the situation here. Uncertain diagnosis, some extra esophageal manifestation or some complicated manifestation, then you can go for the diagnostic test. Or if your diagnosis is in doubt, then definitely you need to go for that. Atypical symptoms associated with complication, inadequate response to therapy. We have used the medical therapy, but it is not working in the patient. Who knows, there is hiatus hernia present. So until and unless you treat that hiatus hernia by surgery, probably patient will not respond. Recurrent symptoms, and prior to anti-reflux surgery, okay, we need confirmed diagnosis. Otherwise, that big surgery is not necessary, isn't it? So diagnostic tests are necessary. Okay. Now, in today's class, we just see what are those tests, and we'll continue in the next discussion. So look at the name. These are the tests: barium swallow, endoscopy, ambulatory pH monitoring, and esophageal manometry. These are the important type of investigation which can be done for the confirmation of GERD or to rule out certain other differential diagnosis. Because in the beginning, I may not know this is a case of GERD, right? So these are the tests done. Let's move further. Now, what is the role of barium swallow here as the investigation? This is a useful first diagnostic test for any patient who presents with dysphagia. Dysphagia can be a presentation in GERD, in a complicated type of GERD, dysphagia is a presentation. So there are so many causes of dysphagia, so we need to rule them out by doing certain investigation, and one of that is barium swallow. So if there is a stricture, barium swallow will show that where is the location and how long it is. Stricture formation is common after GERD. If there is a mass, barium swallow will show that mass, especially it will be shown like a filling defect. Okay, mass means cancer or carcinoma. So filling defect is shown. Where is it? In the lower third of the esophagus, middle third, or upper third, and how long it is, it will be shown. Bird's beak appearance. Now tell me, bird's beak appearance is seen in which condition?
Achalasia, sir.
Condition.
Excellent. Achalasia cardia or achalasia. So this is also a differential diagnosis. Bird's beak appearance is not seen in GERD. Please don't think like that. It is to rule out other causes of dysphagia. The points are written here. And even hiatal hernia. What is the size and what is the type? Is it sliding type or paraesophageal type? Sliding type of hiatal hernia is associated with GERD, but paraesophageal is not. And that is one of our topic today. The limitation of barium swallow in this case in GERD is we cannot examine the mucosa in detail by barium swallow. So even the diagnosis of Barrett esophagus is difficult. So barium swallow doesn't have a big role to play as an investigation purely in case of GERD. So to rule out other differential diagnosis, we can go for it. Another one is endoscopy. Okay, now see there, these are the indications for endoscopy in case of GERD. Alarming symptoms like dysphagia, like bleeding. Okay, empirical therapy failure. We have already started the medical therapy without investigation, that is called empirical, and they failed. Preoperative evaluation means you have planned for surgery, so endoscopy has to be done just to make sure where is the problem. And detection of Barrett esophagus also can be done by endoscopy. Now see here, this is an endoscopic picture. Now see, this pale type of mucosa which is shown in the endoscope is by squamous cell, and this pink type of mucosa, see this, okay, the pink mucosa is a metaplastic type of mucosa, means a columnar thing. So detection of Barrett esophagus is very easily done by endoscopy. And if it is suspected area, then we can take a biopsy as well. Another type of investigation is called 24-hour pH monitoring. That is also known as ambulatory 24-hour pH monitoring. Now, please look here very carefully. You can clearly understand what they are trying to show here. This is a normal person, and this is a GERD patient. See this? This is the time of the day according to the hours. Okay. Now, what a difference you have seen in a GERD patient than in the normal patient? Just see there and tell me. Anybody?
So there is more acidic because there is less than 4. This line is more.
Yes, yes. Good. Okay. Yes, Irfan. Good. Yes, Uzair, you go on. Yeah, sure.
Sir, it is clearly showing a decrease in the pH less than 4. And sir, and sir, we know that that a decrease in pH means on the acidic side. So sir, it's clearly showing that that it's quite acidic after that time of the day, and sir, due to its below 4. Sir.
Exactly. Absolutely. Both of them are correct, and all of you can see that. See this line, this white line, see here. Okay. This is the normal, means in the esophagus, this pH monitoring is done. So there is no presence of the acid here, no presence of the acid. Okay. So it is like, above 4 at the region of 6.5 to 7 approximately. But in case of GERD, now see here, look at this. This is because of the reflux of the acid, and pH is definitely less than 4. So this is because of reflux of the gastric acid up towards the esophagus. Just pay attention there, your answer is right there, okay? So this is a clear-cut case of gastroesophageal reflux disease. Now, let's talk about the treatment Okay, GERD, how treatment is done. What are the goals first? The first is elimination of the symptom. The most common symptom is heartburn, water brass. Okay, heartburn is like a chest pain. Patient doesn't feel comfortable. So elimination of the symptom. Heal esophagitis if it is already there, and usually it is present there. It is known as reflux esophagitis. Manage or prevent complication like extra esophageal manifestation or some complicated form, and maintain the remission. Remission is a state of cure, okay, state where signs and symptoms doesn't exist. So you have to maintain that particular situation. Now, how we do that? The first thing is lifestyle modification. Now, see here, these are important points. Elevate the head of the bed 4 to 6 inches, because if the pillow, okay, is a little bit less thicker, or if the head position is lower than the chest or abdomen position, then there is a high chance of reflux, especially after taking a large meal, and if the person quickly or immediately go to bed or lie down somewhere, especially in obese patient. This is very, very common. So elevate the head of the bed. Avoid eating within 2 to 3 hours of bedtime. Lose weight if the person is overweight or obese. It is highly advisable because obesity is very, very common, commonly associated with GERD. Stop smoking. Now, smoking will cause dysfunction of the lower esophageal sphincter. Okay, that lower esophageal sphincter will not function properly. Remember, it is a physiological type of sphincter. Okay, this is not anatomical. There is no thick muscle there. So all the pressure which is present in the abdomen, isn't it? The peristaltic movement, the angle of the esophagus, the length of the esophagus, everything is maintaining that lower esophageal sphincter. So smoking is making that LES, we say, lower esophageal sphincter, dysfunctional. And modify the diet. Eat more frequent but smaller type of meal. Do not take large and heavy meal at a time. That will increase the pressure inside the stomach. It will increase the transit time of the stomach. Okay, so there is a more chance of reflux. Avoid fatty or fried food, peppermint, chocolate, alcohol, carbonated beverage like Coca-Cola. Okay, Coca-Cola and those type of drinks should be avoided in this situation, even coffee and tea, because all of them will increase the hydrochloric acid, okay, inside the stomach, which is not good in this situation. Let's move on. Now, another type of therapy is to decrease the acid secretion itself. And every student know what are the drugs here. Look at the name: S2 receptor antagonist or PPI, proton pump inhibitors. Okay, so any of the example you can write here, like cimetidine, ranitidine, famotidine, and nizatidine. Among PPI, omeprazole, lansoprazole, pantoprazole, esomeprazole, rabiprazole, so many are there. Now, GERD is a chronic relapsing condition. Relapsing condition means even after the medicine is stopped, the signs and symptoms may come back. So 50% or more relapse within 2 months, and 80% or more relapse within 6 months. So lifestyle modification has to be done along with the treatment. If the person is not losing weight, whatever treatment you do, probably it doesn't work. If the person doesn't change those lifestyle, like doesn't quit smoking, doesn't quit alcohol consumption, okay, that's particular affection about the fatty food and those things, if patient doesn't stop them, then the disease will relapse again. Now, there is a role of surgery in case of GERD, okay, but surgery is not done in the beginning. Surgery is always done for certain indication. I mean, there has to be indication for surgery. Like these indications are intractable GERD, means medical therapy has failed. Okay, this is known as intractable. Fortunately, this condition is rare though. Okay, like intractable GERD may result in stricture, and these strictures are difficult to manage by conservative or medical management. If there is severe bleeding from the esophagitis, which is seen in intractable GERD, and if there are formation of non-healing ulcer, then we have to go for surgery at the earliest. If GERD requiring long-term PPI in a healthy young patient, this is also indication for surgery, because how long the patient takes medicine? We cannot give medicine for so long time. Okay, so surgery would be better. And persistent regurgitation or aspiration symptom, this is extra esophageal manifestation. It can give rise to a lot of complication in the respiratory tract. So we have to go for surgery. Now, what type of surgery we are going to do? See here. So the basic principle is same one. If there is hiatus hernia, which is causing GERD, especially sliding type of hiatus hernia, okay, you reduce that hiatal hernia. Then restore the intra-abdominal esophagus. Okay, if it is going upward, you restore it inside, because the angle which is maintained by that intra-abdominal esophagus is helping the lower esophageal sphincter mechanism. This is a very important point. Approximate the diaphragmatic crura so that the hernia cannot occur, and perform fundoplication. This fundoplication means, again, these all important mechanisms are done for the treatment of hiatus hernia. Okay, hiatus hernia is very commonly associated with gastroesophageal reflux disease. So these are the important surgical treatment which are mentioned here. What are the complications of GERD? Now, every student know that, every student can list these complications here. These are erosive or ulcerative esophagitis, okay, which is caused by the reflux of the acid. Esophageal stricture formation, also known as peptic stricture. Stricture is a narrowing of the lumen of esophagus because of chronic esophagitis, okay, because of fibrosis. Barrett esophagus and adenocarcinoma. Now let's see some of the picture here. Okay, now see this. Look at this, picture here. This is the endoscopic view of the esophagus. Look how narrow is the lumen. It is extremely narrow. And if this is a complication, then person will have severe type of dysphagia. Okay, severe. Now another clue for you is, look at this fibrosis. Okay, this area looks a bit contracted already. This is called fibrosis, and this is because of the chronic inflammation which is there as a result of reflux esophagitis. And if we do barium swallow, because of this has a particular length, length. So it will exactly look like this. A small amount of barium will pass below, and it almost looks like bird beak or a rat tail appearance, isn't it? But remember, it depends which area of the esophagus is affected here. If the lower esophageal sphincter or lower end of the esophagus is affected, then it is very commonly mistaken, okay, or confused with achalasia because of the barium swallow examination. But we have certain other clue for us, like we should take a history, should do some other examination, other investigation. So GERD diagnosis is not that difficult. Now, this is Barrett esophagus. So many times you have seen this type of picture. This is the endoscopic view. Now see this pale mucosa is the normal esophageal mucosa, and this pink or reddish mucosa is columnar epithelium. So this is clearly metaplastic epithelium there. So Barrett esophagus. And this is a gross morphology. Look at this pale type of mucosa here. Okay, this is stomach. See this? This is stomach. Okay, this is a cross section or open view of the inner part of the GI tract. And look at this red granular area which are extending up. So this is known as Barrett esophagus. These days, a lot of the examinations are including this type of picture and ask you the diagnosis. They will give a bit of clinical clue. So you see the picture, okay, then think about the differential diagnosis. This is quite easy. Now, third one is esophageal cancer. Esophageal cancer. Now look at this endoscopic view again. Look at this mass here, see this? A bit of ulcerated mass, a clear cut case of, cancer here. And this is the barium swallow appearance. This is known as filling defect. Okay, filling defect. See this? Why it is called filling defect? Look at the thickness of the barium here, and look at the thickness. It is decreased. Now, why it is decreased? Because from the side, the mass is coming. So this is known as filling defect. It is very, very important feature of mass in the esophagus, mainly caused by carcinoma of the esophagus. Both squamous cell carcinoma as well as adenocarcinoma will look like that. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.